Great. I want to welcome our viewers to this podcast on hypertrophic cardiomyopathy titled, and that's Living with the Arrhythmic Consequences of Hypertrophic Cardiomyopathy and AFib and Sudden Cardiac Death. Joining me today are Dr. Ethan Rowan and Dr. Rob DiDomenico and a couple patients. So let's start. Dr. Rowan, can you tell us a little about atrial fibrillation in patients with hypertrophic cardiomyopathy? How common is it, and how does it impact the lives of patients with HCM?
Mark, thanks for having me today. AFib is really common in HCM patients. About 20% of HCM patients have symptomatic AFib episodes. It's the most common sustained arrhythmia in hypertrophic cardiomyopathy. In addition, if you look at patients who have implanted devices, an additional 20 to 25% of patients will have asymptomatic episodes that don't come to clinical attention. So potentially 40 to 45% of all HCM patients will have atrial fibrillation, making it one of the more common disease pathways in HCM. That being said, it's a really important arrhythmia for a number of different reasons. One is it's often very symptomatic and can really impact patients' quality of life in terms of either palpitations or worsening symptoms of dyspnea and exertion and fatigue. AFib and HCM is associated with high risk of embolic stroke, and that's both clinical AFib and probably subclinical AFib as well. And when not appropriately treated, AFib has been shown in numerous studies to be associated with increased mortality in this disease.
Great. So let's go to the second question. Dr. Rowan, what are the underlying mechanisms that belie the development of atrial fibrillation in patients with HCM?
AFib and HCM is complex, and it's probably an interplay of a number of different things that lead to AFib development. Some of it is the underlying physiology within the left ventricle of HCM, meaning patients have a stiff, thick heart with diastolic dysfunction. They can have obstruction, which precipitates mitral regurgitation, and that leads to increased left atrial pressures. That contributes also to increased left atrial pressures, contributes to increased atrial size. There's probably underlying fibrosis that occurs, which is more in HCM than other forms of heart failure, including HFpEF. The genetics of HCM also leads to what's likely a primary atrial myopathy, with different genes being associated with higher risk for AFib. And then there's also the underlying comorbidities, which we're well aware causes AFib in the general population, such as obesity and obstructive sleep apnea, all putting more pressure on the atrium. And all those interplay to lead to AFib as a population level, with some drivers more important in individual patients.
Great. And now we want to bring a patient perspective into this podcast. And, can you describe your experience regarding how you were diagnosed with atrial fibrillation and how it impacted your quality of life?
I was diagnosed at HCM at age 16, and I went largely without symptoms until age 28. I was given an ICD at age 22, still without symptoms. Because I was asymptomatic for so long, it never occurred to me that I would ever have any issues, and I lived a very normal young adult life. But one regular old Saturday night, everything changed. I started feeling sick, but I couldn't figure out why. I didn't know if it was my stomach. Was it something that was just in my head? I asked my boyfriend, who's now my husband, to follow me to the restroom, and I nearly collapsed. I got an ICD shock that saved my life, and this was my first bout with AFib. It also turned into ventricular tachycardia. I went on to have 15 bouts with AFib that required treatments of some kind. 4 cardioversions, 3 ablations, and multiple medication changes. Ablation number 4 is on the calendar for this fall. AFib impacted my quality of life in many ways. I suffered from PTSD after my first ICD shock. I spent months afraid to be alone for the fear that the AFib would come back. Because the AFib had led to VT, I wasn't able to drive for 6 months. I had a full-time job 45 minutes from home and a boyfriend who also lived 45 minutes from home. I had to rely on my family and friends to keep some semblance of a normal life. As the months passed on and I was allowed to drive again, I started to feel better. Then 6 months later, it happened again. This time I was driving and still unsure of what AFib really felt like. I thought I was having a panic attack. I became afraid to drive, and it took me a while to recover from that fear. After some new medications, I was able to go 3 years without any AFib. Then my worst nightmare came true. I was in AFib in a restaurant with a heart rate hovering around 200, right in my shock zone. An ambulance was called. I was loaded onto a stretcher in front of everyone. For a year after, I was afraid to go out in public. If I went to a restaurant, I had to be seated near the door. It had to be during off hours. At the movies, I had to sit on the aisle. I needed to have a quick getaway prepared at all times. I could only go out with people that I really trusted. I now had a bag packed and ready to go in case of a hospital stay. Being prepared did make me feel better. Then came the ablations. After the ablations came all the post-op AFib, which can happen in HCM patients. After the first ablation, I landed in the hospital 4 times with post-op AFib. The 4th time, I once again went into AFib, but this time I was driving alone, and the anxiety caused my heart rate to skyrocket, and I got an ICD shock. This was 7 years ago, and to this day, I am still suffering from PTSD when driving alone. It's something that is hard to manage, but I have a great support system, which means the world to me. I have my moments of fear, but there are also moments of calm because I know how to handle it when I experience AFib. My family and friends know what to do. I have my doctors on speed dial. It doesn't get any less scary when it's happening, but it does get less intimidating to think about.
My daughter was diagnosed with AFib about 1.5 to 2 years after receiving her ICD due to several episodes of SCA when she was 16. So quite young, for having an AFib diagnosis. And it was discovered not because she felt any symptoms, but the doctor got the recording, got the download from her ICD, and it showed an episode. It was very short. It was only about, I think, 3 minutes long. She didn't feel anything. She happened to be riding her horse at the time that it actually happened, which, made us a little bit concerned. And so we had the really difficult decision at that point about her riding and what she was going to continue doing. Because her AFib was just paroxysmal and she didn't have many episodes and they didn't go on for a long period of time at any instance. At that point, they only wanted to put her on Xarelto. So she was put on the anticoagulation medication at that point. And I was actually able to find a Facebook group of clinicians who were also equestrians. And I posed the question to the group about allowing her to continue with her riding. Because at the time she was doing what's called eventing, which means she was doing jumping in a stadium over jumps of different heights, as well as cross country, which is where they're going through the woods and over logs and over branches and over bushes and through water and over rocks and boulders and things like that. And although they do have to have a helmet and have to have a vest on, we were really concerned with the fact that should she have a fall, would she be able to get medical treatment? Would the Xarelto be able to be turned around quickly? Would there be a more severe situation if she ended up with a brain bleed or internal bleeding or something of that sort? So we did make the decision to have her stop her jumping. She was able to continue doing dressage, which is just in the ring, the horse trots around and, canters once in a while and things like that. It was her least favorite part of riding. Jumping was her favorite. And that was probably the biggest and hardest decision we had to make, because it really did have a significant impact on something that brought her pure joy.
So let's go on. Dr. DiDomenico, what medications can be used to control symptoms of atrial fibrillation in patients with HCM? How safe and effective are these therapies in patients with HCM?
So similar to treating AFib in the general population, there are two approaches to managing AFib symptoms: rate control and rhythm control. However, because AFib is often poorly tolerated by patients with HCM, as the tachycardia can worsen the LVOT obstruction, rhythm control is often the preferred approach, which may differ a little bit than the general AFib population. If you look to the right and to the guidelines here, when rate control is utilized, beta blockers and non-dihydropyridine calcium channel blockers such as verapamil or diltiazem are preferred in this setting, either alone or in combination. While digoxin is an option for the general AFib population, its positive inotropic activity has the theoretical potential to worsen the LVOT obstruction and should probably be avoided in patients with HCM who have a significant gradient. However, in the absence of a gradient, it might be considered if beta blockers and or calcium channel blockers are either ineffective or not tolerated. When it comes to rhythm control, several options actually do exist, and therapy can and should be tailored to the individual patient. In fact, if you look to the lower right here, this is a paper that both Drs. Rowan and Link had published several years back describing their experiences, and they found that in general, amiodarone was the most efficacious, and that the risk of serious adverse events was relatively low among the four drugs: amiodarone, sotalol, disopyramide, and dofetilide. However, what you see is that between 20 and 40% of patients may stop these drugs within the first year due to poor efficacy and or side effects, and only about a half of them actually remain on these drugs at 3 years. So long-term efficacy and poor tolerance limits, to some extent, the pharmacological rhythm control in HCM patients.
And Dr. Rowan, what role does catheter ablation play as a rhythm control strategy in patients with atrial fibrillation and hypertrophic cardiomyopathy?
As Dr. Domenico said, the drugs can be effective, but younger patients, some don't want to be on drug medications, other will have refractory AFib despite medications. And that's where we really start thinking about catheter ablation for those patients, weighing their preference of drugs versus a procedure. Catheter ablation is in general less effective in HCM, meaning over a 5-year period, about 60% of HCM patients will have recurrent AFib after an ablation. That being said, that doesn't really tell the full story, in that with the use of multiple ablations and or antiarrhythmic drugs, most patients really can maintain sinus rhythm. This is a study out of Italy, which looked at rhythm before AFib ablation and then after 6 years of follow-up, what their AFib or status was. And in that study, majority had persistent and a minority had paroxysmal AFib. And after ablation at one or more and or antiarrhythmic drugs, about 2/3 were maintaining sinus rhythm, 8% had a breakthrough paroxysmal episodes, 10 had persistent AFib, and only 18 had developed permanent AFib with contemporary treatments. So I think, Mark, interested in your approach, but our approaches tend to be aggressive with AFib ablation. Obviously, there's a lot of data out there in the general population about being more aggressive for ablation, but often also have multiple ablations and use antiarrhythmic drugs in combination to maintain sinus rhythm in our experience. What are your thoughts, Mark?
Yeah, I've become much more aggressive with ablation, similar to other patients. In fact, I will usually go to ablation before an antiarrhythmic drug, unless they really want an antiarrhythmic drug. So I actually think the results of ablation are better than drugs, and I actually think, to be honest, it's actually safer than drugs. So yes, we moved to ablation early on in patients with HCM and AFib.
The other thing to consider is in obstructive patients who also have heart failure symptoms from outflow obstruction, a surgical ablation, where a surgeon with a Cox-Maze procedure has the ability to perform a much more aggressive ablation. In addition with that, they're relieving outflow obstruction and thereby lowering left atrial pressures by decreasing a concurrent mitral regurgitation. And so if you look at freedom after 3 years from AFib, after a myectomy and Maze, highly effective in preventing recurrent AFib with 3-year freedom from recurrent AFib, about 70% after that combination.
Dr. DiDomenico, how does stroke prevention differ in patients with AFib and hypertrophic cardiomyopathy compared to patients without hypertrophic cardiomyopathy?
You know, I think this is a great question and a potential pitfall for clinicians not familiar with treating patients with HCM. I think there's 2 important points to make. One is that the stroke risk in patients with HCM and AFib is much higher than that observed in the general AFib population. And 2, the stroke prediction models simply do not work in patients with HCM. So the table to the left here really depicts this. In the red box, you can see that patients with a CHADS-VASc score of 0 to 1, which is commonly associated with a stroke risk in the general AFib population of less than 1 to 2%, have a substantially greater risk of stroke between 4 and 10%. And as many as 1 in 3 patients with more additional risk factors for stroke may actually develop a stroke in the setting of HCM. So therefore, anticoagulation should really be considered for all patients with HCM after the first episode of symptomatic AFib. Similarly, because of the elevated stroke risk, even patients with subclinical AFib that was detected from cardiac devices and/or monitoring should be started on oral anticoagulation. Although there is some debate about the duration of subclinical AFib that warrants anticoagulation. And you can see some of that depicted in the guideline recommendations there regarding the duration of AFib. To the right are the guideline recommendations that reinforce these points. And the point I'm really trying to make here is that when choosing an anticoagulant, the direct-acting oral anticoagulants, or DOACs, are typically preferred to vitamin K antagonist or warfarin in each instance, whether it's symptomatic or subclinical atrial fibrillation. Dr. Rowan, you've published some of your experiences regarding anticoagulation in HCM patients with AFib. I wonder if you can describe a little bit of what you've observed.
I think that anticoagulation in patients who have known AFib is extraordinarily effective. In fact, in this paper we published in 2017 of a cohort of over 300 patients with AFib, only 18 patients had strokes. Of those, 14 were actually off anticoagulation, and just 4 of the patients had strokes while on anticoagulation. At that time, it's 2017, so I'd say it was a mix of warfarin and DOACs in that population. But now, I mean, it's almost only DOACs that we're using for treatment of AFib, and our experience is the same. Notably, there were just 2 stroke deaths in our cohort. And again, both of those were off anticoagulation. If you compare that to prior literature in HCM patients, and this is from Iacopo Levoto's study in Circulation in 2001, at which point over 50% of patients were not on anticoagulation. In their cohort of HCM patients, almost 1 in 5 had strokes. So I think we're doing a really good job in patients who have AFib in preventing embolic strokes. That being said, a lot of that is potential under recognition or not starting anticoagulation timely, and that's the care gap I think that we have.
And a lot of this data regarding the time frame of AFib and risk for stroke is extrapolated from other conditions. And it's pretty clear that if you have clinical AFib, your stroke risk is increased. If you have AFib greater than 24 hours, your stroke risk is increased. If you have AFib less than 6 minutes, it's not increased. But this 6 minutes to 24 hours is sort of gray. We're not exactly sure what to do with that. Now, Dr. Rowan, do left atrial appendage closure devices have a role in stroke prevention in patients with AFib and hypertrophic cardiomyopathy?
I think there's underlying concern about left atrial closure devices as a primary treatment strategy, mainly because patients with HCM do tend to have a pretty dilated left atrium and potential left atrial dysfunction. So in someone who's otherwise a candidate for anticoagulation, really that is not our strategy with the left atrial closure device. Certainly is unstudied in HCM, but a lot of hesitancy in someone who can be on anticoagulation. Certainly, if there's particularly high risk of bleeding or recurrent bleeding on anticoagulation, it's a different scenario to reconsider. But again, a lot of hesitancy, at least on my behalf, given left atrial dysfunction in this disease and an unstudied treatment. Do you agree with that, Mark?
I agree that it's unstudied. And as in other patients, anticoagulation should be the bedrock of therapy. But we are using it in some patients, especially the younger ones, and especially those who have bled or have risk factors for bleeding. Okay, let's go back to our patient. Can you share your experiences regarding your decisions regarding symptomatic control of your atrial fibrillation? And for example, was it a rate strategy or a rhythm strategy or an ablation strategy? And what about anticoagulation?
After my first few experiences with AFib, I was put on anticoagulants to prevent stroke. I have a family history of stroke on both sides, so it was important to me to be proactive. I have tried 2 medications. One of them worked perfectly, but unfortunately my insurance stopped covering it, and therefore I had to switch to a brand that causes severe bruising and increased chance of bleeding. That's been a process to manage, but I'm getting through it. It wasn't until my 3rd experience with AFib, which required cardioversion, that my doctor suggested an ablation. Funnily enough, I landed in the ER 4 days before my scheduled surgery in AFib. Recovery from ablation is pretty easy as far as surgeries go. However, the post-op AFib that happens in HCM patients can really put you through the ringer. After my first ablation, I landed in the hospital multiple times. 6 months later, they did a second ablation. My post-op AFib began immediately. Within a few days, I was admitted again and taken off my first antiarrhythmic and put on a more effective yet more toxic medication. My doctors didn't like this, but what could we do? I was in my early 30s and being on this medication was risky. Eventually, I came off this medication, and while we waited for it to get out of my system before putting me back on my original medication, which is far less toxic, I ended up in AFib again. Instead of wait, they started me back on my original medication right away. I made it almost 2 years without an issue, but then landed in AFib again. With my out-of-town wedding fast approaching, we decided to do a 3rd ablation quickly and put me back on the dreaded toxic medication again. We didn't want any of the pesky post-op AFib ruining my big day. Well, 5 years later, I still have yet to come off that toxic medication. There just isn't a medication that seems to work for me. This fall, I'll have ablation number 4, and the plan is to take me off this medication after the ablation to see if ablation number 4 did the trick and that one of the better medications will work and keep me in check from here on out.
My daughter's AFib is something that happens very infrequently at this point, thank goodness, and is also something that the instances of AFib seem to be very short. So, and also she doesn't feel it at all when it happens. So we, at this point, are only doing the anticoagulation to prevent stroke. That's something that I know would increase if the AFib were to increase. Obviously, her risk of stroke increases if the time frame that it's happening in, you know, or when it happens with her, it's typically less than 2 to 3 minutes of it. If it goes on longer, obviously there's an increase of stroke. So at this point, luckily, we really just have to do the anticoagulation medication. Certainly if it gets to be more profound and it's happening more often and she starts feeling the symptoms and having the dizziness and other things that go along with AFib, then at that point, we'll have to make the decision to, you know, to choose an ablation or something like that. She just turned 21, so it's her decision at this point. I mean, I guess it has been for a couple of years, but, you know, hopefully that would be something that she would seek our guidance on before jumping into making such a, you know, difficult decision on her own.
Great discussion on AFib and HCM. It's not the same as AFib and other conditions, and especially with the stroke risk being high, we should not be using JADS vascular. So great. With that, let's move on to sudden cardiac death and ICDs.
Okay, so in addition to atrial fibrillation, patients with HCM are also at high risk for ventricular arrhythmias and sudden cardiac death. Dr. Link, I wonder if you could elaborate more on the risks of ventricular arrhythmias and sudden death in patients with HCM and the underlying mechanisms that contribute to this risk.
Yeah, so HCM is a disorder of the myocardium, and you have myocardial disarray, you have scarring in the myocardium, and that puts you at risk for both ventricular fibrillation and for ventricular tachycardia. You also have, you know, myocardial ischemia that plays a role. You have higher LV systolic pressures. And, you know, we know that not all patients with HCM are at the same risk of sudden death, but there are certainly some that we are quite concerned about and should get a defibrillator.
Okay, Dr. Rowan, how should the risk of sudden cardiac death be evaluated in patients with HCM? You know, what tests can patients expect to be performed and how often?
So we really rely on a risk marker strategy in HCM, looking to identify one or more major risk marker in these patients, with even one potentially enough to consider primary prevention ICD. So the traditional risk markers that we use include family history of sudden death in a first degree or close relative from HCM, an individual patient who's had unexplained syncope, multiple repetitive runs of non-sustained ventricular tachycardia seen on an ambulatory monitor, or someone who has an extreme form of HCM with massive LV hypertrophy, wall thickness approaching 30 millimeters or greater. Generally, sudden death risk is higher in younger individuals and substantially lower in individuals over the age of 60. So threshold, even in the presence of one or more of those markers in someone who's older, is higher to implant a device. Also, from the update in 2020 guidelines from 2011, 3 new risk markers were added into the algorithm, including LV apical aneurysm, thin-walled scarred akinetic aneurysm at the apex, which is part of HCM, a large amount of lake out of limb enhancement, typically approaching 15% or more of the LV mass, or end-stage HCM, which in HCM is defined by systolic dysfunction with an ejection fraction of less than 50%. Notably, abnormal blood pressure response to exercise is no longer included as a major risk marker for sudden death in this disease. So as part of the yearly assessment, it's important to think about these risk markers in terms of testing. So in a young individual, echoes every 1 to 2 years, ambulatory monitors on an annual basis looking for NSVT, and then a baseline cardiac MRI, and then typically the thought is to repeat that MRI every 3 to 5 years looking for potential scar progression to adequately risk stratify patients.
Great. Thank you, Dr. Rowan. Dr. Link, what is the role of implantable cardioverter defibrillators or ICDs in patients with HCM, and what complications may occur in patients who receive an ICD?
Yes, ICDs largely prevent sudden death due to ventricular arrhythmias. They're very effective in that, and they're very effective in hypertrophic cardiomyopathy, including both transvenous ICDs and subcutaneous ICDs. So in a person that has risk for sudden death, they should be considered. Now, in a person that has none of the risk factors, they shouldn't be considered. Complications are real because typically you're implanting these in younger individuals. And so they're going to live with that device for 40, 50, 60 years. And we know the weak link in the device is the lead. And so with transvenous devices, the ICD rubs over the lead every time you move your shoulder, and therefore the leads aren't going to last forever. We tend to think if we get 10 to 15 years out of a transvenous lead, we're quite happy with that. The subcutaneous ICD, on the other hand, doesn't have that kind of movement and friction, and we expect the subcutaneous lead to last much longer. In fact, I've never seen a subcutaneous lead fracture, in my lifetime.
Great. Thank you, Dr. Link. The next question is really for both of you. Which patients with HCM are you, or do you consider the best candidates for an ICD, and how do you engage patients in that discussion?
I think it's looking at the profile of that patient and looking for those risk markers, and then weighing that those risk markers towards that patient. And again, one or more in general is enough to start thinking about an ICD. But then, it's important to really engage the patient in that process, discussing with them really the strength of those risk markers and the limitations of some of the risk markers as well. And then obviously also weighing the risks, as Dr. Link was saying, of long-term living with an ICD. And then as part of that also, though, is also kind of the physician judgment on each of those individual risk markers, whether or not weighing all those things together, it's really enough to move forward. Ultimately, it's a complex decision because it's a young patient population, but you're dealing with sudden death here, and it's important that the patient plays a partnership in that discussion and decision-making process.
Dr. Link, is this consistent? Oh, sorry. Is this consistent with your approach to engaging patients and shared decision-making related to the decision to use an ICD?
Very much so. I mean, the patient has to be engaged in this. The patient, the parents, this is a big decision. It's not something to be taken lightly, but, as Dr. Rowan said, you are dealing with sudden death. And in especially young patients with HCM, that's devastating.
Well, now I'd like to move to our patients and get their perspective regarding the decisions to have an ICD placed. So can you share with us your experiences regarding your decision to have an ICD placed, and what were the factors that influenced your decision to do so?
So I had my ICD placed very quickly, actually, after I received my diagnosis of HCM, probably within about a year. I was not having any severe symptoms at that point in terms of passing out, things like that. I did have some near fainting episodes, quite a few of them early on. Medication seemed to be doing fine, though, in terms of abating those symptoms. But I had lost 5 uncles to sudden cardiac arrest. And that was something that was, I think, the main driver behind the recommendation for me to get an ICD. And there was actually, at the time I was living in Colorado and going to a hospital in Denver, but I had been diagnosed and seen by members of the team at Brigham and Women's Hospital in Boston, which was the team really that kind of had followed my whole family for many years. And And there was a difference of opinion between those. My doctor in Colorado, he wasn't an HCM specialist, but he had seen people with HCM because he had not recorded any really crazy rhythms with me or anything that caused him, true concern. He didn't think that I should get the ICD. It was the team here that had followed my family for so long and seen other instances of some pretty severe outcomes that they were the ones that actually were recommending the ICD. And so for me, it was not, I need to decide to do this because something could happen at any time. It was, what's going to make me more comfortable going forward, and how am I going to feel protected? And so honestly, I got the ICD because I almost wanted that insurance policy, right? I wanted to know that should something happen, even though my doctor in Denver hadn't seen anything, that I would have that protection. So that I've had ICDs now for, it's been 25 years. I've been paced once. It's never shocked me. I'm on my 5th battery. So looking back, I probably should have followed the Denver doctor's advice because, every time you open someone up, there's increased risk of infection, and certainly leads can be an issue. My leads are pretty old at this point. So it was a decision that I made at the time just because I wanted the extra protection that I ended up actually not needing.
One of my doctors actually was very adamant, was my EP doctor, my electrophysiologist. However, my cardiologist was not, and she figured I was too young, even though I was a perfect candidate for it. She did not want to put it in at a young age, which was roughly around 27 or 8. However, my EP doctor was very adamant, and they could not come to an agreement on it. It was not for probably another 7 or 8 years until I received genetic testing and found out that I was in fact a carrier of HCM, along with all of my symptoms and my echoes and all of that. That at that point is when my EP doctor took over and said, we are doing this and we are putting in this ICD because she should have already have not made it this long. And so we are not taking another day, and we are doing this. So that's at that point when we pretty much, I found out that I got these results. Literally, I had an appointment 2 days later with my EP doctor, and I got this inserted a week later.
Well, thank you to both Doctors Rowan and Link. And on their behalf, I want to thank you for participating. Clearly, patients with HCM are at greater risk for sudden death, and ICDs are an important part in improving survival in this patient population. But as both Doctors Link and Rowan explained, the decision to pursue an ICD is a very personal one for patients and requires shared decision-making. As the last in our series of HCM podcasts, we would like to get some final thoughts from our patients. What key points do you think healthcare providers should consider when talking to patients with HCM and shared decision-making?
When a doctor is talking to a patient about HCM, it is so important to lead with the positive. Anything that comes with a heart condition is scary. Use terminology that is familiar and that they'll understand. Smile at them, be friendly. Let them ask questions and make sure they know how to get in touch with you. Make sure you have an open door policy so that they don't feel scared and alone with nothing but the internet to answer their questions. Make sure they know that you're leading their team and that you're going to be there for them.
My advice for caregivers around HCM is, I think so often patients come into the office and on that particular day, maybe they're feeling fine, right? They're feeling, and we often say we're feeling fine too, when we aren't necessarily. So it's kind of, patients with HCM, we learn to adjust to our symptoms. And so those things that were problematic before are now fine because we've adjusted to them. But having our clinicians ask us, when I saw you a year ago, what could you do then that you're struggling with now, that you're not able to do now? And so that they can really get that overall impression. And I think that also educates the patient to be a little bit more mindful, because we do like to forget how we felt a month ago, especially if we felt lousy. And so it also helps us to go, okay, wait a second. Yeah, 6 months ago, I was doing this and I haven't been for the last, 4.5 months. And that can be, that can be due to a change in your condition. So, I mean, shared decision-making is such an important part. And I think that's something that's so new also to HCM care. It used to be very paternalistic. Your doctor said, don't exercise, you didn't exercise. Your doctor said, take this medication, you took the medication. And now I think it's up to both the doctors and the patients to start realizing that they're both a very important part of that care team. The patients need to be made to understand that you are a major part of your care, not just the recipient of it. You are not your condition, you are a person with the condition. And so reminding the doctors and having the doctors remind the patients that their voice really does matter. Ask the questions about why you're taking a particular medication. I think it's easy for doctors to just say, take this, and, it might alleviate that. I think doctors need to go in sometimes a little bit deeper and be, this is what's going on with your heart. The medication works in this way. This is the mechanism of action. This is what we're trying to take care of. Bring the patients into those conversations, because it can't be a top-down approach. It has to be a level playing field, and the patients have to feel as though they are playing on the same field as the clinicians.
They need to listen more to patients, and listen to what their concerns are, and listen to what their previous health history is, and even this being a hereditary disease, and knowing how deep that can go, and even looking at the outlook. I went into many doctors, many cardiologists, and told them, my history of this is my mom and my sister, both, prominent people in my life, have died from this disease, and at young ages. And here I am at a young age, and I'm asking for this device, and it's being denied to me. And I have all the symptoms, may not look and appear as though I may be, worse off than some, but I am definitely experiencing everything. And to my knowledge, my sister never really experienced much, which is why she went undiagnosed. So I think that it's very important, especially with all of the symptoms, and just being very aware to the patient's, concerns, and hearing them out, and coming to the best decision for the patient, but also, take in consideration what their wants are as well.
So on behalf of Drs. Link and Rowan, I want to thank everyone for participating in the vodcast today, Living with Arrhythmic Consequences of Hypertrophic Cardiomyopathy. Hopefully from our discussion today, you understand that atrial fibrillation and HCM patients is not the same as atrial fibrillation in the general population. The stroke risk is much higher. The success of our therapies for rhythm control have some limitations, and often require a personalized and a combination approach as far as the management of those that atrial fibrillation. In terms of sudden cardiac death and the potential role for ICDs, certainly the ICD has a role in terms of improving survival, but as I mentioned earlier, this is a very personalized approach. requires shared decision-making with the patient, really a partnership, as I think both Drs. Rowan and Link alluded to. So I want to thank you for participating in this activity with us today. A lot of important points about living with arrhythmic consequences of hypertrophic cardiomyopathy were discussed. This activity is supported by an independent medical education grant by Bristol Myers Squibb. The views and opinions in this activity are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the AHA. To get additional information, please visit AHA's Hypertrophic Cardiomyopathy website for more education. Thank you.